Hello and welcome to the Well After Hours. I am your host, Beverly Allen, and I'm so glad you joined us tonight. My guest tonight is Dr. Kyra Norris, who is a family medicine physician with over 20 years of experience caring for patients and families. Dr. Norris is passionate about building trust in healthcare and also about helping people take charge of their own well-being. So tonight we're diving into one of the greatest health challenges in the nation, and that is the diabetes crisis in America, what's behind it, and what we can all do to help bring real and lasting changes. So now let's go in and welcome Dr. Norris. Welcome to the Well After Hours. Thank you so much for being with us today to come and share with our viewers what I hope will be a very informative and insightful conversation on this crisis in America with diabetes and, the family. So thank you again for being here with us.
Thank you for having me. I hear I'm in good company. My Dr. Sheldon Holder, I've known him since I was 18 years old. We were both biology majors together at Oakwood College, now university. And then his wife is one of my best friends, Kelly Holder. So I've been knowing them since I've known them longer than I haven't known them. And to me, they are the epitome of wellness and health for the African American community and all the great things that they have done as far as cancer research and mental health and well-being. So I'm honored that they introduced us.
Yes, you came with high ratings, let me tell you. And you know what? Actually, speaking of ratings, and we're going to get into that, I have to say and let the viewers know when I was kind of researching your background and things. Mm-hmm. And one of the things we always tell people, that they usually look for are reviews of other, patients or customers on products or whatever. And you had 5-star rating reviews.
I'm glad you went on the right app. Because, of course, unfortunately, fortunately and unfortunately, patient ratings have become a very big part of the healthcare system. In fact, it kind of judges now how Medicare rates you based on what the patient experience. Of course, our goal is always to give patients a 5-star visit when they come in, but sometimes that rating goes down because they didn't like what you wore that day, or they don't like, I had someone who gave me a bad rating because they didn't like that I had a purple streak in my hair. So there's a lot of things that come into play. So rating is good because just like when we go to restaurants, we want to make sure it got an A rating. But there's a lot of other factors in the healthcare system that determine whether you get an A or you get an F. So that's just a sidebar, but I'm glad that you ran across the ones that had a good experience.
Yes, I did, and there were many of them too. So I'm appreciative of that, even so. But before we dive into the whole discussion, I wanted you to tell the viewers a little bit how you got into family medicine and what the difference is between family medicine and specialties.
Okay, so I guess let's debunk the first thing. Family medicine is actually a specialty. Mm-hmm. It used to be used, family medicine and general practitioner used interchangeably, but general practitioner usually only has like 1 year of residency, doesn't have any board certification. Whereas with family medicine, we actually it's a 3-year residency program, and we sit for boards, family medicine boards, and get certified in family medicine. So that's what distinguishes us from just a general practitioner, meaning that we actually do the 3 years of training, just like you see with internal medicine, just like you see with general surgery. So we are a specialty. And what's different about us is that we are from womb to tomb. So we can see from babies all the way up until you're on hospice or your final days here on this earth as we know it. How I kind of stumbled into family medicine. So from high school on, I thought that I was going to be OB-GYN, obstetrician gynecologist, really wanted to deliver babies. And then I hit medical school. I went to Loma Linda University, and I realized that I enjoyed delivering babies. And I enjoyed preventative women's health. But all the other surgery stuff I wasn't really interested in. So I said, wait a minute, we got to regroup here. Then I thought I wanted to get into pediatrics, and I went on my pediatric rotation, and outpatient was good, but inpatient, seeing kids so sick, I wasn't really vibing with that either. I enjoyed internal medicine, which is more of adult medicine. It was like the first rotation in medical school where you actually feel like you're part of the team and feeling needed. But I needed something that would allow me to incorporate all of those aspects that I enjoyed. And that's how I got into family medicine. I trained at Florida Hospital, which is now known as Advent Health in Orlando, Florida. And at the time, we were an unopposed family medicine program, which means that on every rotation we were on, there was no other residents that we were competing with for patients. So we got a good spectrum all around care. And it's allowed me to go through doors that I probably would have never went through if I hadn't chosen family medicine. And I just recently transitioned from just doing all outpatient to now I work with the residency program full time. So we are training the next generation of physicians. So I'm excited because always in the back of my head, when I was in residency, I said, man, I would really love to be like part of faculty for a residency program. And then I forgot about those dreams and wishes, and God kind of threw it back in my lap. So that's also a side note to never forget the dreams. Right. So it was a dream I had. And then I was like, oh, well, faculty residency programs, they don't make any money. I gotta pay off this Loma Linda student debt. And then it just kind of fell back into my life. And the team I work with here, it's one of the best teams that you can have. Like when I say that we are a community, a family, that makes all the difference in whatever line of work you're in. You know, having the people that you know have your back, that you can laugh with, that you can cry with, that you can share more of yourself with, that makes you want to, that's a community. And that also rolls into us taking care of patients. When patients feel like we're part of their community, then they're more willing to listen to the things that we have to say. So that's the community that we create with each other, as well as we try to create with our patients over here.
You know, I'm so glad that you brought that out, that family medicine is a specialty. Because, you know, coming up many moons ago when I was a little girl, you know, it's like the family doctor did everything.
Right.
You know, it's like the dentist did everything. And so you weren't kind of triaged out to different, you know, persons who have, I guess, who are just specializing in that one field.
Definitely.
That had to do everything. And so I look at the family medicine as really heroes, because they, you know, they have to give you, they're like orchestrate everything. They have to, you know, determine where you go, somewhat who you see, and know everything that they do so that you can orchestrate the whole care together, putting all those packages and things together to know the patient.
Definitely. And, you know, in the rural communities, in the rural areas, like family medicine, some of them are doing a lot of procedures, doing a lot of things that we would usually outsource to other specialists, you know. And so, you know, there is a real need, especially because we're seeing, especially in a lot of rural areas, there's just not the health care that people should have. You know, I worked in, when I first got a residency, I actually did locums, which is the equivalent of a traveling nurse. I was a traveling physician. So I would just go different places where they needed help. One of the places I went to was Alaska. And when I was working in Alaska, you know, they would say, oh, in the States. And I say, you know, we're part of the States, you know, because things were just done a lot differently. And I went and worked in a small village called Caltech that at the time only had 235 people living there. No type of healthcare providers there. So, you know, even though we have a lot more access to healthcare than some other countries have, there's still a lot of people that don't have access to healthcare. And so, you know, having family physicians in those areas that can do multiple different things, that can do minor surgeries, that can deliver babies, that can do C-sections, you know, that can make a world of difference. We already know that, in women's health, here in the States compared to other countries, we have more complications with deliveries. So, being in those areas where there really isn't much healthcare is really important. Like the family medicine physicians play a key role in those areas in helping get patients care that they normally wouldn't have. And even specialists fly into Alaska 1 or 2 times a year. Same thing when I worked in Guam at our Adventist clinic. I did some work over there, knowing that the allergist only comes during the summer. Even though we're part of the US and we're supposed to have this great healthcare system, there's still a lot of us who are not getting the healthcare that we should be getting.
Wow. Whew. That being said, oh my goodness, if it's that tough for most people, it makes me wonder, like in Black and Brown communities where communities are really struggling, and
Yeah.
major cities, where they supposedly have everything, but we don't really have access. If it's not healthcare, we don't have the insurance, or we just don't have,
No, and I do live in Las Vegas, Nevada. And when I first came here, when my husband and I first started dating, he told me, you're in a medical desert. And I didn't really believe him until I saw how hard it is for us to get patients in to see specialists, because compared to the amount of the population that lives here, there are not enough providers for where we are. So, and we're in a major city. So if in a major city, you can still have a long wait time to get in to see a provider, whether it's primary care or whether it's a specialist, ear, nose, and throat, the wait time for some of them is like 8 months, So if we're in a big city and we feel like, we have access when we really don't, just imagine all the other places. Just imagine, that small town in Alabama, or, that small place outside of New York City where, you don't have the same amount of providers. So unfortunately, even though we feel like we have a good healthcare system, there's still people that have insurance. We're not even talking about the people that don't have insurance, that don't have the access that they should.
oh my goodness, and you brought up earlier about, working with residents.
Mhm.
How does the residencies look for Black and Browns, upcoming physicians? I mean, are the numbers getting a little larger, or are they beginning to decrease with all that's going on? It making it
Yes.
hard to even get the education that many would like to have.
So, we have been seeing that, especially in primary care, which primary care includes family medicine, internal medicine, pediatrics, and sometimes OB-GYN is thrown into that as well. The number of applicants for those residency programs has declined. And usually we see swings. So like when I was in medical school, it was a swing more towards specialties being harder to get into. And, primary care was like, so we have a pendulum that kind of goes back and forth, back and forth.
Yeah.
But, today's individuals are a little bit different than the individuals of old, where really people just want to be able to go and do their job and get out, right? They want to do their 8 to 4, their 9 to 5, and nothing extra, associated with that. And that's not really how primary care works. Your hours are usually longer than that. You may not be seeing patients from 8 to 4 or 9 to 5. You might be seeing somewhere in that window, but all the stuff that has to be done after the patients leave. And then COVID probably changed things a little bit more so as well, where, we did see a big exodus in the nursing realm, right? Because nobody really signed up to be in a pandemic. Nobody signed up to be doing with a battle where you thought you were going to lose. So a lot of people in healthcare that could get out and do something else got out.
Mm-hmm.
right? And so it does make more challenges for healthcare, especially primary care, because we're just not seeing the same numbers. So, our residency program is trying to do a bigger push to get into colleges and med schools and have these conversations and talk about still the joys in family medicine. And I'm sure that that's what's going on with PEDS, because I do know that a lot of programs in primary care did not fill their whole classes, and we're trying to scrambling to get people into slots. So that's the scary thing is that people are leaning more towards, oh, if I do radiology or I do pathology, I don't even have to deal with patients per se. I'm just in a room looking at images. So we're seeing some of those things too. And the way psychiatry is operating now as well, they're doing a lot of video visits instead of a lot of face to face. And so it's changing. We're just learning how to pivot, right? With each generation, it's new challenges, and we're just doing what we can just to help as many patients as we can.
Wow. Oh, my goodness. Getting now diving into the subject of diabetes, it seems like that diabetes seems to be touching more and more families these days, and not just older adults, but young people too. From your perspective as a family physician, what's driving this rise, and what are you seeing most often in your practice?
So, diabetes is, even how we treat diabetes is evolving every day, right? But, some of the things that we're seeing is, of course, the American diet is not helping us fight diabetes, right? The whole concept of fast food becoming your staple, right? And then our portion sizes. And we don't live in the times of old where our kids would go outside and play after school and run down the street and ride their bikes all around town, because we're concerned about safety, right?
Mm-hmm.
We're concerned about our kids getting abducted or abused and things of that nature. So the kids don't have the same freedom. And then, so what are we doing inside? We're playing more video games or more time on devices. And, I have to be honest, like, yes, my kids have more time with devices, because what I'm not going to do is let them just be outside by themselves like I was outside by myself when I was growing up.
Yeah.
Right?
Yeah.
Just because things, just the way the world is, it's made everybody pivot on how we move. And, as far as fast foods, and then if, let's just say, we're using SNAP to supplement our income as far as getting our foods, right? So we know that with SNAP, you only get a certain amount that you can spend on food per month. And what is going to cost more when you go into the grocery store? So is the sugary cereal going to be cheaper than a whole grain cereal? Yes, definitely. Is soda going to be cheaper than bottles of water? So, we're in a society where everything that is probably detrimental to us costs less than things that are better for us. If I'm telling my patient, I want you to go in and get organic strawberries, organic apples, organic broccoli, do you know how much of that SNAP that's going to take up? That's going to take up a large portion, and you have to be able to feed your family for the 2 weeks or the month, right? And so we're in a situation where we're really shooting ourselves, because we have created a society where it's cheaper to eat the foods that are not going to be beneficial for us, right? We live in cities where we don't have areas or space to grow our own foods, our own gardens, or community gardens. Patients who don't have cars. So, and if you live in an area where there's not a real grocery store, so you're going to the corner store to get foods in order to be able to feed your family. So what we are saying is that we don't really care about your well-being until you get sick. And then we have different layers of what you're going to be able to afford as far as medications to treat the sickness that we pretty much created.
Mm-hmm.
So it's a vicious cycle. And, unfortunately, in people of color communities, we have also cultivated a lot of diets that are not towards our good. Like you say, it's not a family get together if there isn't red Kool-Aid. And if there's red Kool-Aid, if you didn't put more sugar than the instructions say, then it's not good Kool-Aid. It's not good red punch, and I'm just saying, because I grew up going to Black churches, and I remember there was always the yellow big igloo with red punch in it. You know what I'm saying?
Yes, I
don't
do.
use that, but so I know that it is there, and we've cultivated a lot of things, like a lot of fried foods into our diet, and it's not just the African American community where we're seeing these things, right?
Right.
In our Spanish speaking communities, some of the foods that we're eating are not the best for us, and some of these things were handed down generationally because of the poverty,
Mm-hmm.
right? Like we learned, people of color are good at learning how to make do, right?
Mm-hmm. Yes.
We'll make do. We'll make, you still going to eat well, even though we don't have money.
Mm-hmm.
And unfortunately, a lot of those things are things that contribute to our downfall as far as health is concerned. We African Americans are 60% more likely to develop diabetes compared to our Caucasian counterparts. The only group that has like higher rates really than us is the indigenous people. The indigenous people here, and that is because of colonization, really, because they were pretty fit and pretty healthy until we started trying to, and when I say we, I'm not just,
I know, right.
You know what I'm saying? We put them off on little areas and said, this is your land, even though all of this was their land. We know that they were always growing their own foods, hunting for their own foods, very active. We brought alcohol and introduced that over to them and created alcoholism within the indigenous people community that did not exist priorly. So, colonization really did a number on creating diabetes in that community. Because, if you're drinking large amounts of alcohol all the time and you're eating large amounts of food all the time when that's not what your body was designed to do, we know that as you become more obese, your pancreas cannot do its job and put out insulin to pull those sugars back down. Your body also becomes more resistant to insulin, meaning that it's not, even though you may have a lot of insulin in your system, you're not able to break down the sugars, or the body doesn't recognize it. So, those are the things that are scary about how the setup is. It's like almost like society wants everybody to be big. So, and then we have medications that can help them where they don't be big. But guess what? Those medications cost a lot of money.
Mm-hmm.
And, there have been studies, not just on diabetes, but on heart disease, that we actually can reverse these things. A lot of people don't like to talk about that. We can reverse those things. There was a study that was done, and I can't remember when it was done, but it was basically like going back to a Garden of Eden diet.
Mm-hmm.
And when I say back to Garden of Eden, I mean like this was like hardcore. We weren't doing any butters. We weren't doing any oils, like doing fresh fruits and vegetables that were organic, like very healthy diet. And these people had known coronary artery disease. They re-imaged them after being on this diet for a certain amount of time. And guess what? There was no coronary artery disease. So, when patients tell me that I want to change my life and I know that I can reverse it, I know that's true. But are you really going to put in the work to do that? So, we do have certain groups of patients who they're like, doctor, I'm going to do better. I'm going to change my life. And they do all the tools, they do all the things. And we see, that body mass index drop. We see the diabetes go away. We see high blood pressure going away. because they made the lifestyle changes. We see cholesterol numbers come back down to where they should be, or even better than they should be, when patients are willing to put in the work. Unfortunately, we live in a microwave popcorn society where people just want to push a button and everything be gone. But really, like diabetes, yes, there are some patients who can do all the right things and still don't have the success that we would like them to have. But definitely a lot of these things are really treatable by changing your life.
Mm-hmm.
And, that's one thing that a lot of people have kind of stepped away from, because it's like fighting a battle with somebody. Like some patients say that they want to do it, but then they don't follow through. So excuse me, it makes it more difficult when you have patients who say, I'm going to do better, I'm going to do better, I'm going to do differently, but then they don't do any physical activity. They don't make changes and get rid of the fatty foods in their diet. They think that diet soda is going to be better for you than soda is. And we all know that, all the additives that are in diet sodas, it may have less sugar in it, but all that other stuff can increase your risk for other things. And so that's part of the work is that trying to educate our communities. And, it's hard because I hear this a lot in African American communities, and it's not just about diabetes, just things in general. I'm going to leave it in God's hands. And yes, God wants us to leave everything in his hands, but he also wants us to do some work on our end. We can't say, God, open up the windows of heaven and pour out blessings, that there not be room enough to receive it, and just sit on the couch. There's actually some work that has to be done. Daniel and the 3 Hebrew boys, they actually backed it up, right? Mm-hmm. They said, we're not going to eat the king's food. We're not going to drink the king's drink. Just give us a little bit of time and we can show you what we can do, right? And what? These guys were way smarter than everybody else and healthier. Like they thought they were going to be looking all weak and pale. And these guys were healthier than everybody else because they didn't give into what society's recommendations were for eating. Right? And it's hard for us working class people, right? Because we spend more time working than we do doing anything else. And the last thing that a working class mom or dad wants to do when they come home is then figure out like a nice, healthy meal, right? They're like, DoorDash, can you please deliver these burgers or veggie burgers so I don't have to cook anything? And I'll be honest, I love DoorDash. So no shade to DoorDash, but we do try to make sure that we're ordering healthier things when we do that, right? Yeah. Because we know that our kids and we don't have the same physical activity that then we had before people had cars and when people were walking to work and catching the bus way down the street. So you have to kind of compensate for those types of things. So I don't know if I'm really answering your question, but I know we're having a dialogue about diabetes and how it affects our communities. Compared to our Caucasian counterparts, we're like 2.6 times more likely to have end-stage renal disease. So, unfortunately, diabetes is one of those diseases that affects anywhere where there's small vessels. So I always like to tell patients, we've got vessels in our brains, we're at increased risk for stroke. We've got small vessels in our eyes, so we're increased risk for leading to blindness. Of course, we've got the small vessels of the heart, so we're 10 times more likely to have vascular disease than people who don't have diabetes. We've got the small vessels in our kidneys. And so those are all things that get affected with diabetes. Of course, we know that managing our sugars better has better outcomes, but it doesn't lower the risk completely compared to people that don't have diabetes. And, diabetes is one of those that most of the time patients feel fine, right? They're walking around, I feel fine, I feel great. They come in, we do, just our regular health assessment labs and their sugars are 300, but doc, I feel fine. And if we try to drop their sugars back down to normal too quickly, they feel horrible because they've just learned to live with those sugars being elevated like that. So, when we talk about hypertension, we talk about diabetes, we always say those are silent killers because most of the time people really don't realize it for years because we, people of color, we don't go to the doctor the same as the counterparts do, right? Mm-hmm. And we are justified in those reasons. We all know, the Tuskegee experiment. We all know that story, right? Let's give these people syphilis and let's see what happens. Mm-hmm. So how is that going to evoke trust? We all know that there was times where we could not go into normal hospitals, and some of us died because we could not get to the hospital where the doctor who knew what was going on was there. We know in the 1980s, they were actually sterilizing people of color without telling them in California. And that's not just Black people, that's Hispanic people already. You were sterilizing us and not even telling us. And then, of course, Indigenous people, we just treated like you were not even from here. So why would any of those groups be excited about going to the doctor? If I know that over generations of time that you have been doing things to us that you shouldn't be doing to us, and I know that African Americans have a higher rate of amputation secondary to diabetes compared to everybody else, mm-hmm. Why am I going to run to the doctor? And that is one of the battles that we're trying to overcome is getting people to trust us. And, I do have a lot of patients of color who've chose me specifically because of what I look like, mm-hmm. not because of what they heard about me, but because they figure that maybe you'll want to take care of me the way I should be taken care of. And, so those types of things are also barriers that limit people to access or if you have a family member who had a very bad experience and, when they're coming in trying to talk about their diabetes and the doctor just says, you're fat, you need to lose weight, and doesn't give you anything to help you with that process, so we just don't have the connectivity to the healthcare system because of things that happened to us years ago. And yes, we are asking people to forget those things, but it's hard to forget those things.
Exactly.
It's hard to forget those things. And when you hear stories, there's stories about patients not being treated properly or being taken care of the way they should have because of what they look like.
Yeah. So like you mentioned, excuse me, I didn't mean to cut you off, but the thought just came to me. Look at what Serena Williams, when she was about to deliver, what she had to go through. She had to push to get somebody to look at her. Now, if somebody like her with her means and in her position had a hard time, and other persons of color who were in financial situations where they could have handled and were paid, had great insurance and died because in child delivery, it made no sense because somebody didn't listen to them when they listened to their bodies and was trying to tell them that there was a bigger problem here.
Let me tell you, yes, that is like Serena Williams' story. Like, she's like, I know what a pulmonary embolism feels like, and I have one. And for them to just brush off and push aside, and when I had my daughter, Kailani, after delivery, I lost a pretty good amount of blood, just to be honest with you. And I was a little bit afraid because I was looking at the rest of my family, looking at the baby, and I was like, Lord, please do not let me die in this room while everybody's happy about this baby being born. And I had an African-American physician, and she was trying not to freak me out and trying to stop bleeding and everything. But I did not have her for the care afterwards. And when I went home from the hospital, my hemoglobin was pretty low. And the nurse even tried to talk to the doctor that was on duty on time and be like, should we really be letting her go? Because it's kind of low. And I didn't realize until I got up and started trying to walk and I was dizzy. And I'm just thinking, man, if a physician, and they knew I was a physician, is getting treated like this. But what's happening? What's happening to everybody else that can't advocate for themselves and don't have enough sense to be like, something is not right. So, part of being in healthcare, especially as primary care, is educating patients, right? It's not just about giving them medications, educating them on things that they can do to help keep themselves healthy so they don't find themselves in situations, where they're wondering whether they're getting the care that they need, learning to advocate for yourself. And there's a difference between advocating for yourself and just coming in and being crazy on everybody, right? There's a time to be crazy if you need to be crazy for your family's well-being, but it doesn't need to be every single time. Learning the difference of when should I be advocating and when am I just trying to be over the top to try to make the healthcare do what I want them to do. And sometimes there's a disconnect between those things.
Wow. Being a physician of color, African American physician, does that make your overload greater? Because of patients, we want to see somebody who looks like you. Like you
So
said, there's trust issues there. So, I just wonder,
I'm going to be honest, in the realm that I'm in, uh, because it's hard to get in to see primary care, I can't say that, it made my job like I was seeing way more patients, because we were all like really seeing a lot more patients and double booking, doing things that we need to do because we know these patients need care for. I find it an honor when someone seeks me out, right? I don't think of it like as, unless they're like a crazy kind of acting patient. I find it an honor that people want to trust me with their healthcare needs. So I don't really think of it as it's more of a burden. One of the things I've noticed is that I do have a larger Ethiopian population here, and it's because one in particular had a good experience, and they brought everybody else, and they keep trying to convince me that I'm Ethiopian. But
I could recognize that. I can see how they could easily do that.
but it's an honor, and then it makes you feel like, man, how much more effective could I be if I spoke the dialects, right? And that's one thing I just wish, like, I can speak a little bit of Spanish, but not enough to be like, yes, I'm fluent. And I just wish that, in particular, like Spanish dialect that I had in my back pocket, and as well as the Ethiopian dialect, just because we have a larger population here.
Wow.
If I could speak Eritrea, like, it makes a world of difference, because things get lost in translation.
Yeah.
Even when you're using the formal translation line, and like how in the Bible days, like after Jesus left, right, and they were all in the upper room, and they're praying for the Holy Spirit, and the Holy Spirit came down with those flames, and people were just speaking all these different dialects.
Mm-hmm.
Do you know how much more work we could do?
Ooh, what a thought.
And
so true.
and who knows, that may happen again, but
Mm-hmm.
especially like in healthcare.
Yes.
And healthcare, like when people are healthy in their mind and healthy in their body, they're going to be way more receptive to the gospel of Christ.
Sure.
Right. And
So
which is why the healthcare work is important, not just to make people healthy, just to make them healthy, but make them healthy and show them the way to eternity.
wow. That is so powerful, what you just said, and being a physician, a woman of color, and a woman of faith. That's the reason why I spoke to Kelly and Sheldon about having someone of faith to deal with these subjects, because it's got to be, we got to have God and the Lord in that issue, in these issues,
Yeah.
and work around them and be without him, and that means so much more. And that's why you feel the way you do and have accountability.
Mhm.
You feel the accountability maybe sometimes greater than some because of that.
Yeah, and people always say, "Well, how did you know that you wanted to do this?" Or how do you? And you don't ever fully know, but I don't think that when you have a relationship with God, I don't think He puts you in positions just to put you in positions, right? Um, we have a responsibility. We have a responsibility, and that is really not to necessarily preach the gospel, but to live the gospel and to love people, right? And loving people in healthcare is an important thing because patients can feel that. They can feel that
Mm.
if they know that you care. Just like little kids can tell, like, mommy, I don't know, but I don't think this person's a good person.
Mm-hmm.
The same way they can tell when you care and when you don't care.
Don't care.
And so, just trying to translate that into real life is trying to be that person who always tries to show that they care, because we know when providers care, you have better outcomes. You have a little bit more, not saying that it's a magic wand, but you can wear on those patients long enough where they finally decide to get their colonoscopies and get their mammograms and get their preventive health things taken care of. I had a patient in particular. He was coming to me because he just wanted to get his testosterone injections. And I said, let's do some labs just in case. I know you've been seeing an outside provider, but I just want to make sure. And his PSA levels, prostate specific antigens, came back really high. If I would have just continued to prescribe his testosterone without doing those labs, we wouldn't have caught prostate cancer. And prostate cancer loves testosterone. So showing that you care and showing that you love them may not always make them excited, but those things is how we catch things that we wouldn't have caught before. And I'm not saying this to be like, oh, look, I caught this. I'm just saying this to, like, when we treat everybody the same, no matter what they look like, because he didn't look like me, and we want the best for them, then we have better outcomes for everybody, not just for some people, and so that means that no matter what you look like, no matter what you sound like or smell like, we want to have the same standards for everybody, the same standards of care. We are not going to neglect just because you don't speak English fluently. We're going to try to give you the same thing that we give everybody else.
Wow, how did he feel when you gave him that news from having suggested that he take this test? He must have like, oh my goodness.
Yeah. Yeah. He was pretty appreciative, but he was a good person, very good person. But it's those types of things, right? This is why we come to work every day and do the things that we do, is because we want patients to have better outcomes.
Yeah.
We want patients to have better outcomes. It's not just about getting a check so we can pay our bills. It's about providing the best care to our patients. And that is why there's always the fight for primary care, is to be able to do these things, because often the insurance is really what guides how we're able to manage patients. Right? Anything that's been shown to be beneficial to protect heart function, to protect kidney function, to give better outcomes, is going to cost more. Right? It's going to cost a lot more, especially depending on your insurance, than the medications that we know are not that great.
I have to ask you then, with so many persons losing insurance now, what's left for anyone who has no insurance?
So, there are some clinics that service populations that don't have insurance, but part of always the biggest thing is that what happens to the people who are not poor, but are barely getting by? That's the biggest population that gets affected, right? Because there's resources for if you have absolutely no money, you got your insurance if you do have money, but if you're living check to check, you're in that gray zone where you don't really qualify for anything. And I guess this is going all back to prevention, right? So if we can get patients to move more, if we can get patients to make sure that you have more veggies and protein on your plate than you do carbs, then we can stay some of these things. If we're not putting tons of salt on all of our foods and not making sugar the necessary component of every meal, then there's things that we can do on that end. We can't take away genetic predispositions, right? We can't change genes, not yet anyway. Um, but we can change the way we move and what we put into our mouths.
Yeah. Wow. When a patient first comes to you, what are some of the early warning signs that you notice that they might be developing diabetes or prediabetes? And because there's a young population, then there's the adult population, and we've got so many undiagnosed cases, people walking around that don't know. And once I heard somebody heard it said that that the in the USA that you're either pre-diabetic or diabetic. Most of the time is like there's so many. I looked at so many of the statistics, and just for the viewers to let them know how serious this is, I read that there was a piece from the National Diabetes Society, kind of like what the CDC had put out, that there was, and this is in 2024, that a total of 38.4 million people have diabetes, which is 11.6% of the US population. And then diagnosed is 29.7 million people, including 29.4 million adults. Woo! And undiagnosed is 8.7 million people, which is 22.8% of adults with diabetes are undiagnosed. So people are walking around and they don't even know what category they're in. So there's no treatment. And like you say, they don't have any symptoms. So they're just eating and people feel like until I get sick, I'm fine. And that's so not the case.
Yes. So, you can have like things that kind of alert doctors that this might be a problem later on. Like we call acanthosis nigricans, which is basically a darkening of the skin that you can see around like the back of the neck. You can see it kind of like in folds of the skin sometimes. So it's just like a skin darkening that happens. That can be like an alert that, hey, this patient may be a diabetic or may become a diabetic later on. Of course, anytime that we see elevated body mass indexes or elevated weights, we know that, like we said earlier, that there's more insulin resistance or body not able to make enough insulin. So we know that those are people are at higher risk. Sometimes patients may come in complaining of, I'm thirsty all the time, even though I drink fluids all day long, or I'm peeing all the time. Or for females, I get yeast infections all the time. Those are all signs that there's something going on with the sugars. And sometimes when patients' sugars are very high, it can change your vision, making your vision more cloudy. So those are all things that we'd be like, makes us think, maybe we should be checking for diabetes in these patients. But really, like standard of care now these days is that we get health maintenance labs where we're checking those sugars. So, that way, even if you're not a diabetic, if your labs kind of indicate that you're in the pre-diabetes category, we can start having those conversations about things that we can do to keep this from becoming diabetes. Sorry.
That's right. We just had a little technical issue, but we'll be back. Here we go. Here we go.
I'm sorry. It kicked me out of everything. I was trying to get rid of your phone call and it kicked me out of everything.
Hey, that's okay. We're good.
Like, oh my gosh, I clicked off of everything. So, like once again, how prevention becomes more and more important, and trying to get your kids to be like, active in sports, Those are things that can help keep them moving, so we're not worried about our teenagers having diabetes, right? Because, kids like things that taste good to them. And of course, carbohydrate rich foods taste good to most people. And really, the centers in our brain that get excited when we use drugs and alcohol, those are the same centers that get excited by carbohydrate rich foods. So, just developing from the time they're little, uh, like my kids really like broccoli and they like berries a lot too, like just kind of instilling those things. I'm not saying they don't like ice cream because their dad is an ice cream head. They like ice cream. But but like helping them develop like healthier choices from the time they're younger. That and of course when you hit teenage years, everybody gets in this junk food stage. But at least like if you're developing some of the habits, hopefully some of those things will carry over. And like we said previously, kids are not biking outside. They're not roller skating down the street. They're not running down the street playing with their friends like we used to, like to burn energy. So even if you're like playing video games, having the type of video games where it's like action, where they got to be moving around, if your kids need to learn how to swim, having them in swimming classes, because swimming is something that we really like, everybody should really know how to do just to prevent drownings in future. Having them in those swim class, so that they're burning some energy. Having them, if your local gym has like, some of these gyms will teach taekwondo classes and things like that without you paying large amounts of money, where you have them in something that's getting them active, whether gymnastics, like there's so many different things that they could be doing, making them have dance parties in their house, right? We used to do that a lot, especially during COVID. I'd be like, dance party time. We just dancing, freeze the music,
Become creative.
these are all things we can do to help with movement. I'm also certified in obesity medicine. So, we've done some lectures, and my part is always about being active. Like, I can't show you right now, but I have a little walking pad in my office.
Oh,
So do I get on it as much as I'd like to? No. But, you walking in your office while you're reviewing lab results or doing squats at your desk, like there's a lot of things you can do to keep moving and to help try to stave off that diabetes and pre-diabetes.
that is so true. You know what? When you were talking earlier and quoting scriptures, I thought it came to my mind. I didn't want to say, yeah, but the scriptures also said faith without works is dead. you,
Yeah.
you can't say that. Oh, I've said that to so many friends sometimes. Like, say, you keep praying, asking the Lord to help you. I said, but He's saying, would you help Him? help Him help you. You don't work
Yeah,
against yourself. There's something
exactly.
you got to do.
And it's funny that you say that because there was one patient I was trying to talk to about the importance of exercise. And he was like, well, what do you do? And it was funny because the day before I ran 6 miles. And I was like, well, I actually ran 6 miles yesterday. And then he couldn't say nothing. And I was like, like I'm trying to walk the walk too. Like, am I always perfect? No. But I'm trying to do the things too. I'm not just telling you stuff that is for you only. I'm telling you stuff that's important for me too.
Yeah. I mean, like you said, any activity is better than no activity.
Oh yeah. I mean,
So,
like what the American, let's see, the Heart Association, the Heart Association talks about like even 30 minutes of walking
yeah.
5 days a week for heart health.
Yes.
And studies have shown that you don't have to do it all at once.
Mm-hmm. Oh, you can break.
So you could break it into 6 segments of 5. So,
Mm.
when patients say, I just don't have time, I think you can spread out 30 minutes
Minutes.
in a whole day.
Yes.
So, but there's also been some studies, and I am not a morning person, that say people who work out in the morning are usually stick to their workouts better and have better outcomes from working out in the morning. I'm still saying, Lord, fix me on that, because my alarm will go off early every morning. I'll be like, maybe tomorrow. But like starting your day, I guess starting your day with what your spiritual activity, right, is
Yeah.
important. also with some physical activity.
Activity. Yeah,
Right?
doing that while you
Jesus, Jesus often snuck away to pray, right?
yeah.
But he had to walk there.
To get to his place, right? So
Yeah, he had to walk.
bodily exercise profits a little, and, it does do a little something. So
Yeah.
that's really true, and that's so much. And I wanna just take a intermission, not a break, but just an intermission. This is our segment highlight. That we usually go to about this time, and we'll be right back. So viewers, don't go away. We're not going anywhere. We'll be back to close out and to have a few more discussions on diabetes, and we'll be right back. We just want to go to our guest highlight segment where you can learn a little bit more about Dr. Norris and what she does, and we'll be right back.
Hit it. Oh, how you feel, brother? Feeling good. You feel good? Feeling good. Improving. There's so much bone, brother. How you feel, man? I feel all right.
Well, we're back, and I know you enjoyed seeing the guest highlight segment and what we shared about Dr. Norris. And before we close out, I just wanted to round out a few more things with Dr. Norris. Dr. Norris, people viewing, many families are affected by diabetes, and some people may even be receiving treatments. Is there any caution or things like, since sometimes, like I said, there are trust issues that maybe they should be double checking, even though, one physician may have said some things, because I know they're pretty quick to put you on statins and diabetic medicines,
Hmm.
right away, without sometimes giving people a formal chance to try to make a change, see if they can, start. Because usually once they get on, it's like that's it. There's no plan B.
No, I mean, well, I guess it just depends on where you are. Like,
Mhm.
we will always give patients opportunities. Well, at least where I work, give them opportunities to self-help. But there's a lot of factors that go into play here. Like we said, diabetic population 10 times more likely to have vascular disease. And, studies have shown that statins can help reduce some of that complication, which are your cholesterol medications. If you decide that if you're obese and you lose weight, we know that you can reverse your diabetes. If you are um, overeating, eating large amounts of carbohydrates, physical inactivity, those are things that you can do to help improve your disease. And I have no problem with patients saying that they want to, but I need you to follow through.
Mm.
So when we have our conversation again in 3 months, you can't be doing the things that you were doing before. So, like, what's the saying that goes, doing the same thing over and over again?
Insanity. Yeah, yeah.
Insanity.
Expecting something different to
Something
happen when you
different.
keep doing it. Yeah.
So you can't be at KFC all the time and then wonder why you're not getting better results. And sometimes when your sugars are extremely high and your blood pressure is extremely high, we're going to put you on medications because we're not trying to have you stroke out and die.
Yeah.
And I've had patients where they've lost weight and I've pulled them off of medications. So to me, it's not an end all. This is it. But I'm just trying to keep you alive in the meantime while you make your dietary changes. We have patients who've had weight loss surgery who've ended up coming off all of their medications. right? Now we're seeing like there's not enough studies out yet, but the GLP-1s like the Mounjaro and the Ozempic, we're seeing patients drop a significant amount of weight where we end up pulling them off of medications. We end up getting rid of their high blood pressure medications and even sometimes tapering off of them because now they've lost a significant amount of weight and you don't have all those diseases that you had before. So that's why, we know that weight loss really for a lot of these things can change everything. But patients have to be willing to do that part. And sometimes in the meantime, we might have to do a little something else while we're waiting for those things to improve on their own. So I don't want patients to believe like, patients will say things like, if I go on diabetes meds, I know that's it. That means that's the end, that I'm never going to be able to get off. No, in a lot of cases, you can get off of the medications. And it just depends. It depends on, several factors. Like if your pancreas isn't making insulin anymore, then yeah, you're probably going to have to be on medications because the body's just not doing what it should be. Just like the same thing when patients have overactive or underactive thyroid. There's really things that we have to do in order for you to have a good outcome. And I feel like we have put certain medical conditions into categories. Like if your testosterone levels are low, a man's not going to have any problem wanting to be on testosterone, right? Because it's going to improve his quality of life. And that's how we have to think about most medical conditions. We are trying to improve your quality of life. And just because you don't feel bad doesn't mean that bad things aren't happening on the inside of your body. And I think patients also need to start looking at it this way, that these things that we're doing is trying to improve your quality of life, not your quantity of life, right? Because those are two different things. You can live forever and have a miserable life, but we're trying to help you live longer, but have a quality of life as well.
Yeah, that's so true. Boy, that's a very important point that you just, brought forward, speaking about taking medications and the big possibility that things can change, that you don't have to take it all, but you have to be willing, like you said, to, work towards that end. And when you have a physician that is working with you and keeping an eye on your progress as you make even small changes, that there are benefits in that. So that's great too. That is so important. And it gives a whole different outlook and perspective that gives the person the hope that, hey, you know what? I may not have to take this on if I do this.
Mhm. I don't want patients also to be like, oh, you're just saying that everybody's fat. No, and I'm not trying to make everybody sticks either. I'm not trying to make everybody super skinny. We're just trying to make people healthier because we know and we're not saying, oh, everybody needs to lose 100 pounds. No, for some people, like losing 10 pounds can make all the difference for your blood pressure. 10 pounds.
Mm-hmm. That's very true. That is very true. Wow. Well, I tell you, this has been such an enlightening and informative conversation that I just know it's going to, I think bless many viewers. And we're going to share information where people can contact you. They may want to invite you to even speak. Do you go around to speak at different events?
No, I don't really. That's a hidden talent that I reserve for children's ministry at church. And we did speak for the Nevada Academy of Family Physicians at a conference of obesity. We did a presentation on obesity medicine. There is some dialogue about us possibly doing something in Reno for the Nevada Academy of Family Physicians does 2 conferences a year, one in Reno and one in Las Vegas. So I am going to try to start delving into that. I have not. So maybe you will see me somewhere, but God has given me the gift of gab, so I guess I got to use it.
So you may be open to accepting a few appointments, which is nice.
Maybe, yeah.
Well, your help for us today here at the Well has been so informative, and I can't thank you enough. And I praise God for for you, for physicians, for medical professionals at large, but especially for faith-based.
Yeah.
I really do thank God for that, and that you're fulfilling your calling because it has to be people. You don't just go into medicine. It's not the easiest, route to success. You really have to want to, have contact with people and want to help people because that's
Yes,
a
definitely. And Miss Bev, I do have to say thank you so much for the opportunity. It's always nice to touch and agree with others. And if you ever need me back with primary care stuff, I'd be glad to come
oh
back.
oh you on my hit list now. You really thought this was gonna be one and done?
Well, you always can hope.
Yeah, no, no way. You just don't want to lose contact and when you connect with good people, of faith. And I thank God because you could have, look, you're right in your place, your workplace, and you took time to do this for me, and I appreciate it. And for the viewers, so that people could be more informed and better equipped on, handling their health. I know that's a big thing with you is that you want to help people even take charge of their well-being and get some, trust in healthcare. So I thank the Lord for directing me and leading. Yeah, it's no coincidences. I don't believe in that. I've been praying, and then what is this like? First Sheldon, then Kelly, and now you. I'm like, Lord, thank you. You just told me all the right hitters. So I appreciate that. And I certainly will be praying for you, in all the endeavors that you do, that the Lord will just continue to uphold you and
Thank you.
strengthen you, for what you do, because there's just no amount of thanks when you can find a physician that really is doing all that they can to help, especially our people, all that they're going through. It's just any person, but particularly, Black and Brown communities. We need it so desperately, and I thank you. If there's any, before we close out, if there's any closing remarks, I want to give you the opportunity. Anything you'd like to say, um, any last minute thoughts, please feel free to do it. And after that, I'm going to ask you to close us out with prayer, if you would.
Okay. Yeah. I think one of the important things is that God wants the best for us.
Mm.
And part of Him wanting the best for us is not just He wants us to be doing well financially, He wants us to be doing well spiritually, He wants us to be doing well emotionally and physically, like health wise,
Mm.
right? He wants us to be fit vessels so that He can use them. And that's why the health message is so important, because you can lead people to know Him better by the way you carry yourself, by the way you live your life, and by the way that you treat others. And if you're not well in all those areas, you can't do the job that you're meant to do. So I think that our prayer should be is like, Lord, help me to be really living that complete experience. I mean, He can use broken vessels. We've seen Him do it. We saw Him do it over and over again in the Bible. But imagine what He can do with a intact vessel,
Mm.
right? He said if we had faith the size of a grain of mustard seed, we can move mountains. Do you know how small a mustard seed is? I mean, it's like you could barely see that thing. So imagine like if our faith in all those things was that much stronger, we could move the world.
Mm. Mm.
Definitely can move the world. Let's pray.
Amen.
Dear Heavenly Father, thank you so much for this time together and for us remembering and reflecting on your goodness as well as the things that you've called us to do. We ask that you be with everyone who may listen and tune in to this talk today. May they be encouraged in knowing that there's things that they can do to help their health. May we all get moving and ready so you can come again for us. We love you so much. Amen.
Amen. Amen. Thank you so much, Dr. Norris. This has just been a wonderful pleasure, and I certainly will be calling you back again and keeping up and following up with what you're
Okay.
doing. I
I,
really do.
I'm gonna do like Sheldon and Kelly did. I'm gonna do a pass the mic and send you somebody else's name.
Like I told, that doesn't mean I'm not going to call them back
Oh
too.
no.
I'm
But I
calling
think
everybody back. Good, as they say sometimes, good help is hard to find.
well we wouldn't send you any trash, so
No. I listen. No, I know that if you refer, you get good referrals from people that you do know and respect, so I know that. That's why I had no problems when they said that, none whatsoever. It was answered to prayer, so I know what you say in that. It'll be answered to prayer. So, but I thank you. I thank you for being with us, viewers. I thank you for hanging in there with us and for joining us this week. I'll look for you next week, the same time, same place. And please share this conversation over and over again with people that family, friends, even enemies, whatever, who it can help bless them, and we will appreciate it. And so until next week, I'll meet you here at the well, same time, same place. So until then, stay safe, stay well, and God bless you.
thank you.